Public Employees Benefits Board meeting. Appreciate your participating. Recording has just begun. Thanks, Rose. And I'd like to go ahead and call this meeting to order. Let's take roll quickly and see how many of our board members have been able to join already. Siobhan Martin, I see you. Good morning.
Good morning.
Greg Klauser.
Hello.
Good morning. Chicky Flowers.
Good morning, present by video and audio.
Thanks, Chicky. Andrea Fultz, please. Maybe not yet.
Oh, no,
Yes.
I'm here, present. I had
Hi.
to.
Thank you. Kimberly Hendricks.
I'm here. Good morning.
Good morning. Sean Parkman.
He's excused, right? Isn't he on vacation?
I think he might be excused for today.
That's correct, Siobhan. Yep.
Thanks, Ellie.
Yep.
Emily Wong, please.
Good morning. I'm here.
Good morning. And Rep Nose, I see you. You've already said good morning. Good morning.
Yep. Hello, here, present.
Thank you. And with that, let's go ahead and take a look at the meeting minutes. Have you had a chance to review them? And do I have a motion to approve the minutes?
So Rose sent out an amended version of the minutes. I had a chance to review them, and so I'll put forward a motion to approve.
And this is Kimberly. I'll second that motion to approve the minutes as presented from Rose's updated version.
Thank you, Kimberly. All right, I'll go ahead and hand it over to Andrew Hoffheimer to discuss our first presentation. Andrew.
Thank you. Good morning, everyone.
Good morning.
So, with this first presentation, we've got 30 minutes with y'all. And the intent is to go through a quick review of the decisions that you all made last month. And then ask for your vote and approval on the final 2025 rates and fees. If we want to advance to the next slide, please, Maggie. Here's a quick look at our agenda. It more or less what I just stated is the agenda. We'll do a quick overview of your vision. We'll go through the decisions that you all approved in April regarding 2025 program changes. We'll take a look at the composite rate. And ask you to vote on that, as well as ask for your vote in section 4, which is the final rates based on the decisions that you've made in the first 4 months of the year in this renewal process. Excuse me. And then we will briefly touch on next steps as well. Yeah, I think we can advance. I know you all have seen these next few slides a lot over the last few months, so I will go through them pretty quickly. This first of these 3 slides is PEBB's vision for healthcare delivery in Oregon. This slide, as well as the next 2, which are the strategic pillars and long-term goals, sort of collectively serve as the North Star of sorts, and really are intended to aid in decision making. And this next one, the health equity strategic pillars, is definitely a really valuable tool and framework, again, to aid in decision making and really make sure that decisions are centered within equity. And both this slide and the next slide, which we can jump to, long-term goals, are really intended to be living and breathing documents. And so the goal is to update these at least once a year, but also as needed. And on this one in particular, especially as we're working towards developing and ultimately releasing the medical and pharmacy RFP, I suspect that this one will be updated a little bit more frequently in the next 6 to 9 to 12 months. Okay, if we want to jump into the next section, we are going to go through, again, just a pretty quick review of the decisions that were made last month before we get into the rates and final composite rate and ask for the board to start voting. And so this is the combined strategy for how the board opted to achieve the 3.4% cost growth cap in 2025. And so to get there, there was about a $21 million additional cost that needed to be solved for and reduced to achieve that 3.4% mandated cost growth cap. And so there are three buckets, the first of which is the program changes. This bucket really is intended to sort of shift the total cost pie without shifting, or to reduce the total cost pie without shifting costs onto employees. So many of the changes captured within that bucket are of that nature. There are also some coverage enhancements in there as well, based on things that the board determined were important and strategic as well to sort of safeguard plan costs into the future and provide member support. And the next bucket is around plan design changes. This was the Kaiser Pharmacy copay change that the board approved to align the Kaiser traditional HMO pharmacy copays with the Kaiser deductible plan pharmacy copays. And so you can see there the generic and brand copays were increased for the traditional HMO. The other piece I'll mention there, which is not shown, is that the non-preferred brand tier also was adjusted so that the HMO is aligning with the Kaiser deductible plan. So I did want to call that out as well. And then the third bucket is use of reserves. And so this bucket, which accounted for the lion's share of this $21 million problem we were trying to solve for, was largely used to buy down the Providence Choice Plan and the MODA plan to ensure that those maintain a low-cost plan status. And we'll talk about that a little bit more too as we're going through this review section. I'm not seeing any hands raised or any questions, but please just jump in as questions come up. In these next few slides, we'll take a closer look at the first bubble, the first bucket, the program changes. So if we want to advance to the next slide, please. Start with Providence. So for these next two slides, we have included a row for each of the board approved changes. The first of which is around the removal of the dispenses written requirement. This will require members to use a generic drug when there is instead of the brand drug, when there's a generic equivalent available. The next approved item was around extending coverage for hair growth medications for members who have been diagnosed with alopecia areata. Probably mispronouncing that, so sorry to any clinicians on the call. The next one's around updating the value tier for the value tier drugs and asking that Providence update this at least on an annual basis. The next item is also pharmacy related. It removes some over-the-counter drugs from the formulary. And the final item is also pharmacy related. It's a new program called Pharmacy or RX Savings Solutions, which identifies savings opportunities for members based on the drugs that they are filling and proactively assist those members in switching to a more cost-effective drug. So a good way to increase affordability for members. I see there's a question. Yes, Andrea.
Sorry, kind of going back a little bit, and the removal of dispenses written reminded me. So I know that at least from people that I've talked to, there's some generic drugs that are out of stock, and so they have to, the only option is the brand name. Does that mean they have to pay the brand name price? So my main concern is that, like, for those on Kaiser that just got the 15 to the 25 raise, if they have to do that. But anyway, that's just a question I have, is when the generic is out of stock, what are our clients, our members charged?
Yeah, that's a good question. And I don't know, I see Sarah Drake that you're on. I don't know if you know the answer. If not, we can take that back to Providence and figure out how that gets processed in that circumstance. But Sarah, did you have any thoughts on that?
Yeah, I think we can go back and ask Providence. I think the most common is if the generic is out of stock and the brand is dispensed, then it's charged like a brand name for when there is no generic. So it's kind of the same
Okay.
situation if there's a brand with no generic available. That's
Okay, and
usually
is
how it
that the
goes.
same for Kaiser?
I believe so, but we can take that back and
Okay.
ask.
All right, thank you.
Hi, and this
Yeah,
is Gina
great.
Korab, pharmacist from Providence Health Plan. And yes, we did have that example this year where there were stimulants on shortages, where the brand was not available or was available. It just depended on the different scenario. But we can put in an override so that the generic would be the generic price would pay for those medications. So it really would not be the member who has to front the burden of that when there's a drug shortage and there's no available option, if that makes sense.
Yes, that's great. Thank you.
Yeah, great question, and thanks, Gina. Appreciate that. Okay. Not seeing any other questions. I think we can advance to the next slide. Still sticking with Providence. And so this next one is one that applies to all three of the medical carriers, and it's a coverage enhancement around gender affirming care. There's no cost for Providence for these particular items. There are some for the other carriers, which we'll get to, but you know, these are coverages which are high impact for members who are going through gender affirming care services, and so the board decided that was really a priority. And so regardless of the fact that it was sort of a difficult renewal from a cost perspective, there were enhancements that were made, and this is one of those enhancements. The next item is around doulas and adding doulas to coverage with the 8-visit model. I'm really happy to see that one added, as I know many board members are as well. The Progeny network change. And so with Progeny, this is Providence's new integrated fertility vendor. They have their own proprietary network, which largely matches the existing network, but does offer some additional access points. So this will be a nice enhancement for Providence members. Mighty Health, this is a weight management program with an engagement-based fee model, which we like. And so, you know, with weight management programs, one size does not fit all. And so the intent here really was to provide members with an additional choice. So offered alongside Weight Watchers and some of the other support solutions that are in place today. Pause and see if there are any questions or comments. And if not, we will move to MODA. Okay. So the first item for MODA is the clinic level attribution. So this one changes how members are attributed to their medical homes. So previously or currently, members are attributed based on their individual primary care provider. And so this change will attribute them to the clinic that they are going to, which provides a better member experience in the event that a primary care provider leaves a given clinic. The next one's around nutritional therapy. And this is an enhancement that removes the requirement of a diagnosis to be able to tap into this benefit. We've got doula on this slide as well, which we talked about on the Providence slide. There are some gender affirming care coverage and fertility coverage enhancements noted here as well, the second row from the bottom. And then the final row on this slide is around Kindbody, which is an enhancement to the existing fertility network for MODA. Kindbody has their own proprietary clinics. Those clinics will be added to the network. And so similar to the Providence side, it'd be a nice enhancement and additional access points for members who are seeking fertility services. Okay, no questions. So I will assume we are good to proceed to the next slide. We are sticking with MODA on this slide. The first row captures some changes to site of care programs. So these are steerage programs that are intended to get members to an optimal site of care for those services that are bulleted there on the left. From a pharmacy perspective, the board approved removing some over-the-counter drugs from the formulary. So some NSAIDs specifically. Sticking with pharmacy, the Costco 6 for 6 program. This allows members to fill a 6-month supply for their value tier drugs from any Costco. So nice enhancement. This is available for members whether or not they have a Costco membership. Mighty Health, we touched on in Providence as well. This is the additional weight management solution that we've been talking about over the last few months, and will be that additional sort of option for folks who are seeking those services. And then the last row, the Teladoc virtual primary care decision to add Teladoc as a medical home that members can be attributed to. We did want to call your attention to the capitation fee. So you can see we've added that little asterisk there in the bottom right. And so this was communicated as an $11 capitation fee. So this is a fee that gets paid per attributed participant per month. So only for those members who are attributed to Teladoc as a medical home. So that was communicated as $11. That was an error. It should have been $14. And so we have asked MODA to honor the amount that had been proposed, which is the $11, and MODA has agreed to do that. However, come 1/1/26 with the next renewal, that fee would go from $11 to what should have been $14. As of 1/1/26. And so when we're working through the 26 renewals, at that point, we will know how many MODA members have opted into having Teladoc as their medical home. And so we will have that information. We are going to give some more thought to other sort of early indicators that we can look at so that the board can revisit if, a year from now, is a determination made that, yes, it does make sense for Teladoc to continue to be an option within the existing ecosystem or not, given that higher capitation fee. So I want to pause there and see if there are comments and questions on that or on any of these other items for that matter.
So I just have a question around the Teladoc in particular. I know that we're doing a passive open enrollment this coming fall. And is this one of the areas that will be shared so that folks know that this is now an option, particularly for people who are out of state or have children that are out of state, dependents out of state?
I
don't know
think
if
it
that's
makes
more a
sense
question
to-
for Ali. But go
Yeah,
ahead,
okay.
Andrew.
Ali.
I mean, I think definitely we're going to lean on our communications to get the messages out to as many folks as possible, especially considering the number of out-of-state employees that we have these days, for sure.
Yeah, I agree. And those gears are in motion on the communication side,
Yeah.
generally speaking. And so, yeah, I agree with Ali. I think it makes sense to
Have some of
communicate.
that later today, Siobhan.
Thanks.
Yeah.
And I can just add for MODA, we will be including it in our webinars that we provide to PEBB, as well as all of our communication materials that we take to benefit fairs. So we will also be getting the word out in addition to what PEBB does.
And I did want to clarify too, and I think on previous discussions, the board was leaning towards offering Teladoc as an option for dependents who are out of state, but not for subscribers, not for employees who are out of state. So I just wanted to put that out there and see if discussion was required or not around that piece specifically.
Could you say that again, Andrew, that it would be offered for dependents who are out of state, but not for employees who are out of state?
Yes, exactly.
That might be interesting because a lot of us with being no work in the buildings have people out of state now.
I don't remember the context of that. Is there someone on the call who can speak to why that is the proposition?
I think in part it had to do with operational considerations around finagling configuration of the Ben admin system in such a way to extend eligibility. Because today eligibility is driven either by, I don't remember if it's by county or by zip code. So I'll pause there and see if maybe there's someone from the staff team who can either tell me, yeah, that's right, or no, I'm off base on that.
Yeah, we might call that, Andrew.
Ollie, I'm not able to hear you. I don't know if others can.
Can you hear me now?
Barely.
Very, very faint.
Log off.
So I'm sorry, I missed the first part of the question. Can you repeat that? Hopefully I can answer it.
Oh, sure. Yeah. So I was just making a comment on the operational considerations around extending eligibility to employees who do not reside in Oregon, and some of the potential challenges around configuring the system to allow for eligibility for Teladoc or for MODA specifically. And I think the other thing I'll say before Cindy, you react to that is I think there would also be some communication challenges to ensure that an out-of-state employee who's electing MODA for 2025 would really need to know that by doing that, they are also electing a virtual primary care physician to be able to participate in that plan. I don't know if that was clear in my first part of that, Cindy, but it was basically like around the eligibility, configuring the system to allow eligibility, which would be a change for how eligibility is configured today for MODA.
So currently MODA is offered in certain counties in Oregon and some bordering counties. And the board has not elected to change how that is currently being offered. We did have discussion around that, and especially with the passive open enrollment, making a change like that, I think would be a pretty big issue, especially with the system. And so the discussion was to essentially, kind of keep it as is. So there wasn't a discussion around opening up. I mean, we did have that discussion, but it wasn't a decision to open up MODA to become a national plan. It's still kind of being offered in the areas, the counties that you're currently being offered in, and that's based on your zip code of where you live or where you work. And this Teladoc option was really more for those who wanted a virtual presence rather than a physical, or they had difficulties finding a PCP, or those dependents who would be out of state to get to an in-network provider. I think that discussion could be probably better handled next year, whether we want to start talking about better options, and maybe during the RFP process as well. But with the systems as they currently are and implementing a new system, I think it's probably going to be quite challenging to do it, especially in this limited amount of time. That's just my opinion. Cindy, you're nodding. I don't know if you had any other
No, that was
thoughts.
perfect. Thanks, Emery.
All right, and I'll channel my inner Sean Parkman and say, MODA is committed to providing primary care to all of those individuals, regardless, telehealth or in person, whether or not it's through Teladoc. So I trust that they will get what they need, regardless of whether this particular service is available to them, and we can revisit it with the next examination of the benefit. Anybody have more to offer on that at this time? Hearing nothing. Andrew?
Okay. All righty. So I think we can advance to the next slide. So now we're shifting to Kaiser, noting the doula enhancement, as well as the gender affirming care and fertility enhancement. There is an incorrect statement there around coverage being excluded for dependents. That is not the case. There was a handbook correction that was made, but Kaiser had not been administering the plan in that way. Coverage is allowed for dependents, so just please take note of that and just sort of mentally strike that, because that coverage does include coverage for dependents.
Will we be able to post corrected slides so that the document of reference for the meeting has the corrected information?
I believe so. I think, Rose, we can if you're on, we can send you that corrected slide as soon as the meeting is over. If you have a way to amend it in the official distributed board packet.
Oh, sure. That's easy.
Okay.
Thank you.
All right. Thanks, Rose. Yeah, the next item is around another weight management solution, this time with Omada, but similar sort of intent as what we talked about with Mighty, trying to offer members an additional option for those who are seeking support with their weight loss. And then the final item on this slide is the pharmacy copay change that we talked about a little bit at the beginning of the slide, or beginning of the deck, excuse me. And so that covers it for medical. If we want to advance, we're going to shift gears and talk about dental and vision, and then we'll get into some of the ancillary coverages as well. So starting with Delta, and the board did approve extra services being covered for members with intellectual and developmental disabilities. You can see those bulleted out there. From a Kaiser dental perspective, the board approved some changes to the occlusal night guard and athletic mouth guard benefit, both from a cost share and frequency perspective. The Willamette Dental Group plan was renewed on a status quo basis. And for VSP, there was an enhancement on the Plus plan to increase the contact lens allowance to $225, which will now match the frame allowance. No questions. I think we can proceed. We've got one slide here on the ancillary benefits that are being renewed as well. ASI Flex, your FSA and commuter vendor, no proposed changes, so status quo renewal. Benefit Help, your COBRA administrator, status quo renewal, slight rate increase. And WebMD, the board had decided to terminate that program. And so that program will be terminated as of 12/31 of this year. We've got Weight Watchers as well. Weight Watchers is renewing with some changes. As you can see here, and as we've talked about in the previous months, moving to an engagement-based fee model. And so that will be great. We've got some performance guarantees in play, and so looking forward to seeing some outcome data as we move forward with Weight Watchers under this new model. We do have a couple of off-cycle renewals as well. Life and Disability, Unum's long-term care program, and Canopy EAP. And so we are not losing sight of these, but they do have a different renewal timing compared to those benefits we just went through. And so the next few that we'll be working on will be Unum and Canopy as those hit their renewal dates as well. Pausing to see if there are questions and comments. I'm not seeing any, and so I think we can move on to the next section, which is the composite rate and funding decisions. Just 2 slides in this section. The first of which shows the monthly rates for your medical plans. And so these rates are take into account all the changes we just went through on the program side. They include the penalty payments for the trend performance guarantees. They include the decision to buy down the MODA and Providence Choice plans to maintain low-cost plan status, which is why you can see those rates are exactly 10.00% lower than statewide. And just as a reminder, the low-cost plans are those that have more favorable employee contributions. So the amounts taken out of employees' paychecks are going to be either 1% or 3%, depending on if you are a non-Oregon University System or Oregon University System employee, respectively. And if you are not enrolled in a low-cost plan status, then your monthly paycheck contribution will be 5%.
And just to, on that note, it didn't change for the Oregon University System. It was Kaiser deductible this past year too, right? And then for folks who only are outside the Kaiser network, then does that one change?
No, that's correct. So, well, actually, for the outside,
They're exactly the same now, so.
They are exactly the same. So I don't know if there is. That's an interesting question. I don't know. I mean, I think it was Providence choice, I think, if you were outside the Kaiser system in OUS. So I actually don't know the answer of how that's gonna
Well, it
if
should be
there's
the
two
same.
low cost plans.
It should be both because they cost the same anyway.
Okay.
All right.
All right.
So I see Rep Notes, you have a question. Maybe just let's hold on to that until we hit the next slide, and then we will pause and get that question. And so I think we can flip to the next slide. And after we sort of talk through this piece and address any questions at that point, we'll ask the board to make a vote. And so this slide shows both a historical composite rate as well as a projected 2025 composite rate, which you find in the bottom row. Again, this composite reflects all of the program changes and use of reserves and other strategies that the board opted for to achieve the 3.4% cost growth in 2025. And so using the reserves to buy down the choice plan and the MOTA plan almost got us to 3.4%. You can see in the bottom row there's a 0.001% funding assessment that was needed in addition to those rate buy downs to achieve 3.4%. So just want to call that out. Just sort of an interesting coincidence that the buy down just about got us there, but not quite. So let me pause and Rep Nos, if you want to go ahead with your question.
Yes. Since we're using reserves to do what we need to do, I'm just curious, what is the status of the remaining reserves?
Emery?
Yeah. So I have to look up the exact number. I think it's you're above the target for 25, but I think for 26, it does kind of put you, I believe, maybe right at or just below the target. So it is. So there will need to be changes potentially to essentially get the stabilization fund to get in a position that actually meets the target. Ali?
Yeah, good question, Rep. Nosa. I just wanted to mention that we just transferred 90 million to the DAS risk fund about 2 weeks ago. But we do have an updated risk-based capital report, I think from just recently, maybe in the last month or two. So I can share that with you, Rep. Nosa, after the meeting.
Okay,
wanted to
that
chime
kind of
in.
all that went over my head. So can somebody just tell me how much we have in reserves?
Yeah, we can send that to you after the meeting.
Okay. Okay.
I just wanted to note, we had quite a discussion about this in the last meeting, particularly because the legislature took money from PEBB a year earlier than they said they were planning to. And PEBB pays the penalties on that. And then our members don't get to see the benefits of their their actual health benefits when the money goes to the general fund. And the larger the reserve gets, it seems it looks like a fund that the legislature's been going into.
That's probably dynamic.
Yeah, and that was the conversation we had a month ago and made this determination.
It's probably the one I was on vacation. I mean, like, we have to have reserves. I'm not bummed that we're using them. I'm glad we have them to be able to do this. I'm just trying to, as the member of the legislature that's part of this, and Siobhan, I'm totally sensitive to the challenge around the legislature sweeping money for other things. I mean, like, that's a thing, like, and like, I think part of my job in this space is to sort of say to my coworkers, hey, let's not do that. Or when we have to you all, have a good rationale that makes you feel like, okay, in light of everything else that the state is dealing with, we're going to suck it up. I mean, anyhow.
Thanks for addressing that directly, Rep. Nos. It was, in fact, a rather hot subject of debate at the last meeting.
Shocking.
Yeah. All right.
Shucks.
Any
Well, I
more
was on
follow-up on this?
vacation and doing something else probably more fun than this, to be totally honest with you, but okay. All right, Ollie, let's do a proper meeting. Like, don't just send me a document. Like, let's set up a meeting where we just like walk me through it since I missed it. Otherwise, I won't get to it.
Yeah, no problem.
Okay, going back on
Okay.
mute.
Hey, just kind of like a point of procedure, Ollie, do we need to approve this funding assessment level? Because I don't think we had the exact amount determined at the last meeting.
I think we should, for sure.
Okay.
And the board can approve
So-
the rates in a more bulk kind of motion, not, each
Okay.
coverage at a time. So, yeah.
Okay, all right. So then, okay, we'll go through everything and just make a motion for everything. Okay.
So that should be 2 separate motions, Ellie, or 1?
Yeah, 2 would be fine. You could do medical, dental, vision as 1. The funding assessment is 2, and other benefits is 3, if you'd like. If that works, Emery, Andrew.
Yeah.
Okay.
Okay.
Did we want to do the funding assessment motion now or hold until we get through the remainder?
What makes the most sense in the flow?
We could just
Yeah, I
hold
think
to
funding
the end.
assessment. Yeah.
Go ahead. Yeah, go ahead, Ollie.
I was just going to say, I think funding assessment now would probably be good.
Okay. Do I
So I
have
will-
a motion? Yeah.
Yes, I will make a motion that we approve the funding assessment as presented by Mercer.
This is Kimberly. I'll second that motion.
Thank you. So let's go ahead and vote to consider the assessment as suggested by Mercer. Greg Klauser.
Aye.
Thank you. Cheeky Flowers.
Aye.
Andrea Fultz.
Aye.
Emily Wong.
Aye.
And the motion passes unanimously. Thank you.
All right, thanks all. So I think if we're ready to move forward, the next section gets into the actual monthly rates, starting with medical. And so starting with MODA, here we're showing the full-time and part-time rates for the MODA plan. These represent about a 4.9% increase from 2024.
Bless you.
And these are any questions as we go through these? If not, I can just sort of flip through. It sounds like we'll sort of approve these in bulk. So I'll try to keep an eye on raised hands, but just team, if I miss it, please somebody chime in. The next slide shows the Kaiser traditional HMO rates. This is showing both full-time and part-time and HEM and non-HEM rates. These represent a 4.6% increase from 2024. And all of these rates obviously are reflective of all the changes that we've discussed thus far. The next slide, we're showing the Kaiser deductible plan. These are also 4.6% increase in similar format where we're showing full-time, part-time, and HEM and non-HEM. And last but not least, we have Providence, shown both plans, full-time, part-time statewide across the top, full-time, part-time choice along the bottom. The increase for statewide was about 4.9%, and it was about 6% for choice in 2025. Let's jump ahead to dental, Kaiser Dental on slide 27. These are a 2.25% increase from 2024. Willamette on the next slide was a 1.5% increase from 24 to 25. The next slide for Delta, since they're self-insured, we're showing both the administrative fee as well as the accrual rates. And these show about a 5.4% increase in 2025. And finally, we've got vision, also showing the administrative fee plus the accrual rates. And these are a 3.4% increase for the base plan and a 2% increase for the plus plan.
No, decrease.
Sorry, decrease. Thank you.
Sorry, I forgot my mic was on. Sorry.
That's okay.
That's good. Thank you. Thank you for keeping me honest.
Yeah, and just yes, and as Kimberly pointed out, the decrease for the plus plan, is because there was an enhancement, right, for the plus plan that was voted on, and that's applying only to the plus plan, and it only applies to the rates as well.
Thanks all. It takes a village. Appreciate those comments. So that brings us to the end of the rate section. And so, Don, do we want to do a vote now? There's 1 or 2 slides on next steps as well. So I guess let us know your preference.
Let's go ahead and do the rates now, and then we can do the next steps and take it forward.
So this is Siobhan. I'll make a motion that we approve all of the rates for medical, dental, VSP as presented by Mercer.
Thank you.
I can second that.
Is that a second from Greg?
Yes.
Thank you. You're pretty quiet. Thank you. All right. I have a motion. I have a second. Cheeky Flowers. How do you vote, please?
Aye.
Thank you. Andrea Foltz.
Aye.
Thank you. Kimberly Hendricks.
Aye.
Thank you. Emily Wong.
Aye.
Approved unanimously. Thank you very much. Let's do the next step, and then we can come back around.
That's good. Okay. So yeah, thank you, board members. Sorry to go a little over time. With those votes, that sort of wraps up 2025 from a renewal perspective. We will follow up with the exact funding amount that was required to achieve 3.4% as well. I don't know, Ali, if how do we handle getting an approval on that piece, given that there's no scheduled June board meeting?
On which piece, Andrew?
I guess I maybe clarify my understanding. You can tell me if I was off base. The actual funding amount, specific dollar amount used out of reserves to both buy down the rates and the funding assessment.
No, we're okay.
We're okay. Okay.
Yeah.
Okay.
The board made the decision, so yeah, we're good.
Okay. Okay. Great. All right. Thanks. So yeah, no June board meeting. We have some steps on our end that are already underway around confirming these decisions with all of your carriers, working with both staff and carriers on actually implementing some of these changes. And then once the contracts and handbooks become available, we'll begin our review of those as well. And so when we next convene, which will be in July, at least on the Mercer end of the agenda, we'll be ready to talk through the medical and pharmacy utilization review, which is the deep dive we do with you twice a year, as well as a planning discussion around the medical and pharmacy RFP as well. So that's just a little bit of what's to come. The next slide is just sort of a different way to display that information in more of like a horizontal timeline. So not much additional to say here, but I'll pause there. That brings us to the end of the presentation. But if there are any final comments or questions, we'd welcome those as well.
Just a comment that I appreciate Don leading us through the renewal process. It was harder than usual this year, and we had a good discussion last month.
My pleasure and my learning. I appreciate the grace of the board and our consultants and our members for the faith to do the work. Thank you for the presentations and the collaboration. And it sets up some very interesting conversations to have over the course of the rest of the year with this next presentation and our next phase around RFP. We expended some reserves to buy down the rates to meet the growth cap, and we have used our members' dollars to subsidize that, including with the sweep from the legislature. So there are going to be some big picture considerations as we move into that next phase. I appreciate all of your thoughtful partnership. And with that, I'll go ahead, unless there's anything else, I'll hand it back to Mercer. Emery, are you taking lead on this next part?
Oh, yeah, sure. Yes, I will be. Actually, we will be talking about the RFP. And I just wanted to make sure that Ruby is on the call. It's going to take a village, and we will at some point be asking board members to help participate in the RFP in planning and as well as development. But Ruby's actually with the staff and be helping to lead this RFP process from the staff perspective. So Ruby, do you want to I guess, introduce yourself and talk about your role?
Sure. Hi, board members. My name is Ruby Castañeda. I use she, her, pronouns. I am part of the OEB and PEBS contract and procurement team and have been there for the past 3 years. Just to give you a little bit of background about myself, since I'm more newer staff, prior to being with the state, I was in the private sector in the healthcare insurance industry in various roles across various departments, the last being a management role. I am looking forward to working with the Mercer team as well as additional staff and the board to ensure we have a successful medical and pharmacy RFP. Emery, you can go ahead and take lead on this presentation. Thank you so much.
All right. Well, thank you, Ruby. So what we want to talk about was actually some planning and like the kickoff for the RFP in this case. We have some slides here that we're going to talk about. Some of the slides actually we're going to kind of go over a little bit quicker or kind of really gloss over them because we are running a little bit back behind on time, and we'll be discussing some of these topics in more detail in future board meetings, because we will definitely want to hear from the board, kind of like we did at the retreat, your thoughts and actually your views on where the PEB medical plans should be going. Because there's a lot of innovation that's happening in medical services with plans and everything. There's a lot of innovation going on. And there's, meeting that 3.4% and hopefully not having to use reserves to meet that 3.4% is going to be a big topic, especially over the next few years. And so some of the items that we're going to be discussing will hopefully reduce the future trends, and make the members healthier, which also reduces the cost and, really kind of makes the healthcare better for all of your members. In this case, just trying to find improvements where we can. But moving on to the next slide. Just a little bit of the history, just quickly. Last time we did an RFP was back in 2015, as Rep remembers, or has blocked out of his memory. 5 vendors were selected. Kaiser, Moda, and Providence still served. There were 2 others that
No comment.
No comment. Yeah, there were two other plans that were selected that no longer serve the PEB members. And obviously healthcare has changed quite a bit. And the cap has been in since 2017, and this, the costs have been increasing, especially post-COVID. And with all of the inflationary and the other pressures that are happening. And, the value of benefits, obviously, it's very, very important. The benefits are one of the main reasons why people work for the state. You do get really good benefits at a very low cost to members, and trying to keep that is one of the goals that actually came out of the retreat. And on the next slide. This retreat that was held in October, we were holding conversations about the goals and views and vision of the healthcare plan, and some of those priorities and concerns are talked about there, based on the fact that there have been improvements, continuing improvements, and innovations that are potentially wanted, and that the RFP has not been performed for over about 10 years. A motion was carried to proceed with the medical and pharmacy RFP, which we're discussing here. And some of those considerations and details there on the right, but it's like the costs obviously are a big part, because you want to keep the cost down in order to keep the benefits as high as possible for the members. Next slide, please. There were, based on those conversations, there were some viewpoints that were brought across. You can see there on the left, the viewpoints on the provider side. You want to definitely keep as many providers as you can, multiple systems included, and the widest variety that you can. But you also want to have ways to have discussions and improve the primary care services, whether, customer service advocacy to help guide the member through the healthcare system. So that's part of what we're going to eventually discuss in some of the future RFP topics. And then those themes and goals on the right, I think they're just, things that have been talked about with the board quite often, in terms of making sure that all members have access to quality providers, especially on the eastern, the non-urban side, the rural side of the state, and other locations. And health equity and HEI, health equity inclusion aspects of healthcare, and making sure that the plans are concerned with that, and actually trying to improve that. So some recurring themes, and then some questions down below about that were brought up to try to help improve healthcare. Any questions or comments before we move on? Okay, next slide. So the vision, so where we want to go with this, and we'll want to curate it a bit more in the future discussions. It's, we want to focus potentially on care delivery, member experience, health equity, and payment reform. I think these are all things that we've talked about in the past with the board, and the board has indicated a willingness or an eagerness to address. And so in terms of keeping those members healthy and bending the cost curve, essentially keeping those trends down, managing members, and having better, integrated care delivery. That's a key goal, and finding ways to essentially lower the cost without really impacting members too much, whether it's still getting as much of a variety, enough providers, access to providers, but achieving savings through administrative costs, and also through lower cost networks and quality. So in order to achieve that, there's going to be some potential looks at ways to transform the way that care is being delivered, or just trying to find out what the best practices are and what the plans are able to provide, potentially through better customer service or advocacy, and guiding the member to finding the best, highest quality providers, and potentially the lowest potential costs. But also, similar goals to identifying health issues, and just kind of keeping the members healthy as possible throughout their service with the state and universities. Next slide, please. So in terms of planning and timeline, this slide is actually slightly revised from maybe the PowerPoint, and we will send an updated revised deck, but it's just kind of reflecting the timeline that we've discussed with staff and trying to tie it to the board meetings. And we are targeting a January 2027 start date. And so in order to achieve that, throughout 2024, what we're going to do is discuss with the board various topic areas, and we will have a list of some of the bigger topic areas, and we will refine that as we move on. But essentially, over the next few board meetings and the retreat that's going to happen in fall, we will be discussing essentially, again, more of a look at various areas, a more I guess specialized look compared to where we were in last October, but talking about various topics and trying to explore it more so we know how to craft the RFP to really best align with where the board wants to go. And so that discussion and drafting of RFP is going to take place over the next 9 months or so. We will finalize and release the RFP essentially in quarter one of 2025 to the second quarter of 2025, and then the scoring and running of the procurement will happen then in the second half of 2025, with the notification of the apparently successful bidders and contracting happening in 2026, along with implementation and communications with members. With that, I'm actually going to pause to see, Ruby, if you wanted to add anything, or if there's any questions from the board.
I don't have anything in addition to add, Emery. Thank you.
Thanks, Ruby. It is, I don't know if maybe it's giving Rep knows some PTSD or anything like this, talking about the timeline and project planning, but it is there is a lot of work to be done over the next couple of years, right? But I think it's going to be, hopefully as we discuss, the board kind of talks about where you want to go, and we'll try to give you as much information and, improvements and innovations. And hopefully that will really craft, create a cohesive RFP and vision for where we see healthcare for PEB in 2027 and beyond. It's, there's a lot of change, a lot of technology, a lot of things are changing in healthcare. The environment's changing in healthcare. Costs are major issue. And so as we craft this, hopefully there will be this vision that will provide the healthcare that the PEB members deserve. Rep knows.
I'm pretty sure as a non-voting member, I do not get to participate in the process. And it's a good thing to do. It's just it's hard because you have a lot of things to evaluate. And then depending on how many applicants, it's a scoring process. Gosh, Emery, I hope you guys have some other way to make it easier for, I mean, either that, maybe there's not really any way to make it easier. You just have to, whoever is going to do it has to figure out how to set aside the time once you've got all the things to evaluate to figure out how to do it. It was very hard.
Yeah, there are definitely some lessons learned, I think, Representative knows from the last time. I was there during the process. There were definitely a lot of questions. I think we're trying to make it simpler. I don't know if it's simpler. We're definitely trying to reduce the number of questions because it's just the volume.
I lost my Christmas vacation.
Yeah, and we're actually trying to work around that. That's part of the reason why the schedule is the way it is. In terms of the timing of releasing it and the scoring it, we're trying to keep it away from the times.
For a busy person, Christmas vacation's a slow time, so I was able to sort of figure out how to do it. Anyhow, okay, enough of my pain. I remember it all very well. Good luck.
Sure.
I mean, in the same vein of it being quite a burden on a small number of people, is there a way to think about the process being shared more? And, you know, like handing off to different people at different parts, like chunking it out. So it's not everybody has to do, you know, like 2 people have to do the whole thing or whatever, so that, you know, you could do different areas and give information and have people focus on different pieces of it. So, I mean, it would be nice. And I participated in a much less burdensome process with choosing the consultants, and that was a lot of time. And there was just a couple of us, so.
Yeah. Okay. Yeah, we will think about that. I think there's probably ways that we could maybe chunk it out, like have people work on their specialties, but we will, yeah, we'll talk about it and discuss that as part of our planning, at least in terms of the process for scoring or reviewing the RFP. Rep Nose?
I think it's a good idea in practice, Siobhan, but like the behavioral health benefit and the administration and the prescription drug benefit, they all kind of hang together. And I don't know, because this is probably the most important decision that the PEB board makes, aside from the annual benefit design that you do.
Yeah, and Emily, you had posted a question. Yeah, well, I'll take a look at the amount of time. I think you know, as we set it up and talk about getting potential representation from the board as we go through the RFP, we'll definitely determine the amount of time and a much more detailed project planning timeline to lay out exactly what the requirements are for the board members that are participating in, like in scoring and, you know, reading the RFP and being like a more detailed part of the process. I will let you know.
Thank you, Emery.
Yep.
And for noting the time as we move quickly. Yeah. Thank you.
So we actually have a couple of let's move on to the next slide. So we have a couple of sections, one on medical and one on pharmacy. How much time, Chair Lautner, how much time do we have for the rest of this presentation? I know we are slightly later.
We are, so we have a break scheduled at 10:55.
Okay.
If you think you can get it in under that time?
I think we might be able to. So so this next section, Dr. Mary Kay O'Neill is going to be talking about some of the industry insights on medical. And then Sarah Drake's going to be talking about pharmacy. Mary Kay, hate to kind of put you a little bit more on a quicker time frame, but could you, I guess, talk about the next few slides in maybe a more compressed time frame than what we originally had planned?
Yes, I'm sorry. I've had a kind of disrupted schedule today, but I will talk as fast as I can. How about that?
Thank you.
Okay,
And
so
no worries, we will be going over this, you know, care management in a lot more detail in future meetings, but just want to give you a teaser.
yeah. Well, I mean, I know you guys are bombarded all the time with, you know, what's latest and greatest and what's new out there. But I think as Emery has sort of laid out as the future process, we have to keep our eyes on the horizon of what's coming and what could be valuable to people that receive services from PEB. But we also have to be kind of prudent to understand. For example, one of the things in here that gets a lot of attention all of the time has to do with genomics. It's a very interesting, as a clinician, technical part of the clinical and benefits world, but I think we need to keep our eyes on what we actually know, don't know, where the value is, and how this kind of resource may be most appropriately applied to people. And you know, I been
Yeah.
lucky enough to be in a number of different
This is a good
meetings. Yeah, with you guys, and I know that your intent is to bring value to people that work for the state of Oregon, and that's always been my mission with my career as well. But I think we need to be looking at what's new, what's valuable, what's deliverable. In some respects, having been part of the discussions that we've had about various parts of the state, what is supportable, how do we make things equitably available across the state? And so we're not stuck in the past, but we're very practical in terms of what kinds of things would be part of this process going forward, as well as to think carefully about who you need to partner with in order to make this so, right? I mean, that's really what we're looking at on the RFP is not these separate topics per se, but who can work with you to make sure that the right thing is delivered to people. One of the people I work with at another organization that has lots and lots of employees, just like you guys, always says that they are happy to pay for things that lead to a healthy and productive workforce. And you guys have more financial constraints than some, but that's where all the value lies. So I don't know if there's anything here that you want to talk about, but I think like the upper right-hand box, the effective integration of care is one of those pieces that's not as flashy as genomics, but it is the kind of analysis, the kind of understanding about whether what we're talking about is really going to end up helping your folks. I kind of took a philosophic approach to this one. Is that all right, Emery? So
no, that's great. I mean, it is very philosophical. I mean, we really want to know the values. These things are happening, and it's like, where does PEB really see it's like the best meeting between where healthcare is going and where the members' needs are.
Yeah, and I think some of the comments made earlier about how challenging this whole process is going to be for the board, for staff, maybe even for those of us on the Mercer side to do this really well, is that we can start thinking about what are the criteria that we're going to utilize to look at these different topics. And so when we dive into each one, we have a framework, right? So what do we know? How does it work? What does it cost? How do people access it? How practical is it? Those kinds of things. And can we make sure it happens in an equitable fashion? So that's what I think would be important. I think somebody had their hand raised.
Yeah, Ollie.
Oh, thank you. Yeah, just along the same lines. I don't want to underestimate what this would require from the board, and it's a huge undertaking. But at the same time, I think there's so many more efficiencies available to us, tools now to make the process more efficient and less time intensive. I think from the last time when RepNose participated, we had binders that you literally couldn't get your hands around the binders. They were so thick, and a lot of manual
Wow.
kind of work that this time around we'll have access to a lot of tools that will help the board move through proposals more efficiently. Thanks.
Fabulous.
I appreciate the framing of the RFP as an opportunity for PEB to use its leverage to help the healthcare delivery systems evolve in the directions that they need to evolve anyway. And without the financial framework being actively and intentionally leveraged in the directions of health outcomes and equity, the healthcare system is really good at generating a lot of things, but health outcomes and equity are not necessarily the primary outcomes of the system as it is currently set up. So I appreciate the thoughtfulness that is helping us frame an approach toward that evolution, really, and using this process for that. So looking forward to next steps about that.
Yeah, yeah. And good news, Ollie, about the infrastructure to support this obviously incredibly important work. So. I don't want to keep people from their break. Do you want to go on to the?
Yeah. Let's move on to the next few slides. Thanks.
Yeah, so just as you were saying, I think this is, this for me is something that can get lost in the shuffle a little bit sometimes when we are looking at what we want, and we just, as on the other slide, we can focus in on certain treatment types, certain health conditions and things like this. But I think we need to be able in this next process to look at, are the networks that are delivering care doing things a little bit differently, like monitoring the value of what they're doing, monitoring the consistency of care delivery and quality, are working in a way that continuous improvement is occurring. I don't think the improvement challenges of healthcare will ever be totally met. We'll always have new horizons for that, which is good, I think. But I think some of the big challenges that we're going to have is this regional variation. It's very easy for us to think, well, we'll just really soup up the virtual aspects of care in Eastern Oregon, which of course is part of the option, but isn't the whole story. Also, virtual care needs to be quality care. So there needs to be oversight and improvement of that aspect of care as well. I know that there are issues in Eastern Washington, I'm a Washingtonian, Eastern Oregon about broadband access. And I know there are plans at the state. It's not really healthcare, but as it ends up, it is healthcare. It's healthcare delivery that people can access care through that channel. So I think all of those things need to be taken into account, and plans need to be in place to mitigate any gaps that will be in place over the next, time horizon of several years. And so we can make sure that it doesn't matter where you live, in terms of the quality of care and the appropriateness of care that you can access. So just something that sometimes gets, I feel like, glossed over talking to carriers is how well they're managing their network performance. So I think there's one more slide, Emery, and then we can give people thinking time. This is a really interesting evolving concept that we've been following for a long time. And I know you guys are probably very familiar with centers of excellence. For a long time, we've had centers around things like transplant and very highly technical clinical capabilities where you need a very dedicated team and very specialized skills to do that. Over the last number of years, as you may well know, there have been more and more centers of excellence, some of them surgically related. It's been bariatric surgery, there's been infertility treatment, sometimes orthopedic procedures. Now we have things moving into centers of excellence that are more on the medical side, including treatment for substance use disorder, cancer treatment, and things like this. And as this has occurred, the model has changed sometimes so that the center is actually more virtual in nature. But these are some of the things that we can look at both from a network and a carrier perspective around organizing multidisciplinary or complex care and making sure people can access it. And so, for example, in the cancer world, the model is now evolved, which really doesn't require people to travel. It just requires that they engage with a group of experts to do what is kind of like a kind of advanced second opinion, making sure people are getting the right diagnostic workup and treatment planning, and then continuing to work with a local physician to make sure the right thing happens and people can stay close to home. So I think, some people will label something a center of excellence, and, that's not enough. They actually have to have this kind of infrastructure oversight and reporting to make sure you know what you're getting. But I think that is an option, particularly when trying to organize care around more complex medical episodes. So just thought we'd touch on that because that's an evolving concept.
Yeah, and on the COE, we are, continuing to work on this in the IWG, and hopefully we'll provide a lot of data about how quality may vary across the state, or and where you can find high quality providers, and how that can also impact it. So we'll bring that to the board as we get the data and focus in on that. And then the next slide, I don't think we need to go over much. It's virtual care. We've talked about it quite a bit, and it's being implemented. And the coordination is, how they coordinate it. And, it is changing. Virtual care is becoming a bigger part of like a lot of plans, like a strategy in this case. So the next slide, actually, I think, yeah, it's just talking about ways to get PGs. We've been working on this. I think the fees are obviously a big part of it, but the quality and the PGs and the outcomes, really measuring the outcomes. I think a lot of healthcare is about process, but the outcomes of the members, at least to me, is very, very, very important, if not the most important, because you do want members to get healthier. It's not necessarily just how you do it, but it's just like the way, if you have improvement of function rather than just return, or, you follow the procedure. But those things are what we will be exploring in
And
the
Emery,
RFP.
I just
Yes.
have to say, one of the areas of performance guarantee that I'm particularly focusing on these days is engagement rates for target populations, because we often see programs report out that, everybody that engaged with us did great. They all love us. And then you have to ask the denominator question, well, how many people were they? And were they the people you were actually trying to target in the first place? So that's not exactly a process, but that marrying the engagement with the outcomes, the measurable outcomes, and having those metrics as part of the upfront agreement, so everybody knows what you're going to be monitoring, I think is super important at this time as we're trying to wend our way through all this complex world.
Yep, definitely. Yeah, and so the next section actually talks about pharmacy, and we ended up running out of time in the retreat talking about pharmacy, but Sarah Drake wants, has some slides and wants to get some thoughts from the board on the pharmacy and where the board might want to go with the pharmacy plan. So Sarah.
Yeah, thanks, Emery. And I know we're tight on time, so I'm going to try not to take much time. And I really do want to hear from the board and helping us shape what this RFP looks like. So this first slide just has kind of the major trends that are shaping pharmacy right now. And none of these are a surprise, I don't think, for any of you. We've talked through all of these, some at length, at some of these board meetings. So at a future meeting, if there's specific topics here that you want us to dig into, I think we could come back and have a more detailed conversation. Let's go to the next slide. So what this slide shows is just what we call a continuum of different strategies for managing the drug benefit. So what we see on the left is, kind of what I would call table stakes in any kind of pharmacy procurement, right? You need something that is compliant from a legislative and regulatory perspective. Really, you want an exclusionary formulary so that you're not covering some of those drugs that are really just high cost but don't offer any additional value. And then there's this long continuum that goes all the way to the right with some of the more, kind of creative leading edge approaches that we're seeing, like outcomes-based contracts, carving out a specific services, or more like real-time market checks in the market for things like specialty drugs. So we can talk about more of some of these in the future as well, depending on where you want to go with the procurement. Let's go to the next slide. And so with this slide, I just wanted to a high level kind of level set. So there's two major models for pharmacy. There's carve in, which is what you have today, where the pharmacy is part of the larger medical carrier contract. The other option is carve out, where you have a separate contract with a pharmacy benefit manager or pharmacy benefit administrator. There's advantages and disadvantages to both approaches. One thing that's worth noting is typically what we see is with the larger employers, especially getting up over 5,000 employees, and of course you're way over that. We do see a higher prevalence of carve out rather than carve in. And a lot of times we see that because there's a desire, maybe there's multiple medical carriers, but there's a desire to have the pharmacy benefits the same across all of the different models. Sometimes you get better reporting when it's through a carve out, and you can have kind of specific, just more direct control over the financial components in a carve out model. That said, there's advantages in carve in too, and you know, you've probably seen this with some of your existing contracts. You've got medical and pharmacy together in theory. That should allow for more points of integration, more opportunities to really manage the whole person across multiple benefits. So let's go to the next slide. And this is where I really want to hear from you. So this is like bingo. So you can see their bingo card on the left with all of the kind of important things that we talk about in pharmacy when we're looking for procurement. So back when we did the retreat, we talked about kind of the tension of managing between having an easy member experience where everything is covered, they go to the pharmacy, there's no disruption, versus maybe a desire for savings. And that might mean more restriction or more administrative hoops. And so this is where I kind of wanted to open it up to the group to understand what are your top objectives for your pharmacy partner, because that is going to help us better craft an RFP to make sure that you get the pharmacy partner that, you know, that is going to do what's most important to you. Similarly, you know, are there things here that are there things that are deal breakers? Like you absolutely, you know, can't contract with a pharmacy vendor, maybe if it's a non-transparent contract. I know transparency, there's some requirements in Oregon around that. So I'm going to be quiet for a minute and open up for the board because I do really want to hear about what are your top priorities for your pharmacy procurement.
Yeah, and you know, if you want more information about one of the or many of these different little sub boxes, yeah, please ask, and we can provide that additional detail so you have an understanding of what we're kind of asking.
I mean, the one thing that I just wanted to comment on it, this, you know, the optimized financial deal, we have no choice but to pay attention to cost. So, and we know that specialty pharmacy is a huge driver. And I think what's challenging, like what we're seeing around drugs that treat obesity is, you know, we can't afford them. And at the same time, the understanding is if people have access to those drugs, that will in fact mean lower costs over time. You know, hopefully we'll start seeing that data and can figure out how do we offer. I mean, it just makes me think about the public comment that we got today. And, you know, we're talking about we have populations that have been historically marginalized that are more impacted by obesity. How do we address that? How do we address it equitably? And so just, you know, that's going to be a big component of pharmacy too. And I noted, and I wasn't sure, Sarah, when you had the comment earlier around recognizing obesity as an illness, like whether that's like a frame of carriers or pharmacies that if they don't recognize it as an illness, it's treated differently? Is that what that reference was?
Yeah, I would say, I mean, what that comment was about is when we're thinking about what the hot topics are in pharmacy right now, I think over the last maybe 4 to 5 years, there really has been a broader acknowledgement that obesity is a complex and chronic disease. I think when we go back, you know, 10 to 20 years ago, I don't think there was that consistent acknowledgement of obesity. It was seen as more of a lifestyle thing. And you know, we've all grown, we're evolving, we learn more. I think now clearly obesity is recognized as a disease, and that's creating some additional challenges and some additional opportunities in terms of cost and potential cost savings down the line.
Thanks.
So talk to me a little bit about if anybody wants to talk about, you know, that the formulary or the network, like what pharmacies you can use, and is it more important that the members have access everywhere, or is it more important that you have the cost savings? And I did see a hand up.
Yeah, Cheeky. Go
Cheeky.
ahead.
A quick question. I'm trying to figure out why optimized financial deal and transparency of pricing and contract are two separate priorities. Like in my mind, it feels like those are partners. Like those, you can't have one without the other, but I'm sure I don't know everything. So if somebody can provide me with a little bit more detail so that I can parse that out separately in my brain, that would be very helpful for me, please.
Yeah, I think what we're thinking about there is, is it more important for you to get the lowest price? Or is it more important to understand where all of the dollars are going throughout the chain, right? So sometimes within pharmacy, we have contracts that are, maybe not transparent in terms of how much the end pharmacy is paid and how much the PBM is keeping. It's like you're paying this, you're paying an amount for the coverage of pharmacy, but you maybe don't know how the money is distributed between the PBM, whatever subcontractors they have, and then the pharmacy network. And so it's a question of, is it more important to know where every dollar is going, or is it more important to get the best deal with the amount that's coming out of your pocket, if that makes sense? Now, in an ideal world, they're aligned and they're the same thing. But what we've seen is that's not always the case. It kind of depends. But if transparency is the most important for the board, we can structure the RFP in such a way that we can only accept bidders that are transparent and are willing to commit to transparency. Does that help, Chiki?
It does. Thank you.
And I think it sets up a follow-up, which is if that's the expectation and that's what we're getting from all of the bidders, then they're all going to have to lean into that. And I think it helps set us up to look for equity too, in terms of how our end state pharmacies, provider partners in the communities are able to participate with PEBB in ways that some of the biggest players might be able to achieve lower prices by squeezing some of the providers that we want to be supporting because they do a better job, for example, of reaching a particular community. So this is going to be a really interesting and complex consideration. And without more of that, I will have a hard time without more conversation to really understand what these are. I'll have a harder time providing you with priorities. Emily.
Yeah, thank you for that. And I have a question that may not be so directly related to this, but indirectly, and it's an equity question. And I've brought it up in previous meetings. I don't know with this group or maybe like a subgroup. But for example, with Native communities and chronic ear infections that happen to young children, including my own, experienced this when they were younger. Sometimes something that is not pharmaceutical is more effective in terms of treatment. So, for example, chiropractic care, which helps to tilt the tubes inside the ears so that there's more drainage going down versus doing antibiotics. And so is there any way for PEBB to account for alternative health and healing practices as, an option for treatment? So in this example, chronic ear infections and for children.
I think that's probably a great question, and maybe there's some alignment with the traditional healthcare worker work group that CIO is working on this summer. But definitely recognize and hear the question, and that's definitely something we'll need to take into consideration.
Okay, thanks.
Last question, please, Chiki, and then we'll go to break.
Okay, hopefully this will be quick. So just double checking, when we put formulary options as a priority, are we able to share, are we saying that we're able to share maybe PEBB member claims to generate a list of what the top needs can be so that we can provide the proposers a list of like, here are the top claims, and please provide us your formulary options for those. Are we saying we have access to that level of data to be able to provide during an RFP process?
Yes. Yep. Typically, when we do an RFP, what we can do is we'll have a period of utilization data. It might be a year of utilization data from your members. And then each of the bidders will have to bid on that. And they'll need to supply their formulary. And then we can evaluate what the potential disruption is for each bidder. But upfront, we can be clear with bidders if, for example, we want them to bid with their most aggressive formulary that might mean more disruption but could give the most cost savings, we can put that up front, right? Or if we want them to prioritize access and having a more open formulary, we can put that up front too. So it's kind of, we can set the parameters on what they can bid, and then each bidder we can evaluate specifically based on what formulary they bid.
Thank you.
Thank
Yeah.
you, team.
Yeah. Okay. So I know we are kind of running late, so let's just go to the next slide, hopefully real quick. So in terms of the next steps, we're discussing this right now on the planning. In terms of the next few board meetings, these were the topics we were planning on discussing. So a little bit more about care management and case management in July with Dr. O'Neill. And then in August, talking about behavioral health and substance use and how that gets integrated and how the services are provided there. September, I think we're going to have a big discussion about prescription drugs again with Sarah. So we'll provide more detail about some of those options and have that discussion so everyone kind of understands, hopefully understands. Well, I don't know if we'll ever fully understand prescription drugs, but get a better idea of where the options and what's possible there. And then the fall retreat, there's a lot of other topics there that we can have discussions on, as well as follow-up discussions on the stuff that we were planning for the next few board meetings. But health equity is not a specific topic, but it is going to inform every single topic. So that's going to be infused across the board. In this case, I think it's just too fundamental to have that it's going to be a separate conversation. But that's our plan. We will also come up with steps for like the hours and the process for what we're asking of the board, and have those discussions in future meetings. And with that, I think that's the last slide, and I'll turn it back over to you, Chair.
Thanks, Emery. Thanks for speeding that up a little. Mercer team, we're tough when we start asking questions. And thanks for naming health equity as the frame for each of those. It'll be important to be real intentional about that, and I appreciate it. Let's go ahead and go to break. Let's come back and start again at 11:15. Thank you very much, everybody. And welcome back, Dawn Mautner, she, her, and a. Yeah, I don't think I even introduced myself this morning. I'm serving as your chair today for the Public Employees Benefits Board. Welcome back. And if our speakers are ready, I would like to yield the floor for Willamette Dental.
Great, thank you. Good morning, everybody. My name is Tiffany Nicholson, Manager of Client Services here on behalf of Willamette Dental. Dr. Chambers was not able to join with me today, but joining me I have Dr. Eugene Skirties, our President and CEO, also Dr. Whittemore, who's our Chief Clinical Operations Officer, and then Joanna Mullins, our VP of Strategic Business Operations. So today we're just going to provide a quick update on our access and providers for Willamette Dental, and this is just a follow-up presentation from the presentation we did back in October of 2023. Next slide, please. Rose, are you manning the slides, or is there someone that can go to the next slide?
Sorry, Tiffany.
That's okay.
Oh, there we go.
Perfect. Thank you so much. So appointment availability, we use several metrics to measure and ensure appointment availability, access to care, and also evaluating our staff. So appointment availability is measured in average days to be seen for various appointment types. Our operations team closely monitors access, membership, staffing, as well as patient satisfaction. And we're continually adjusting those needs to ensure access to care is acceptable for our members. So we believe an acceptable level of access is to offer our members an appointment within 30 days on average. This does include all general doctor appointments, which would include hygiene, but excludes emergency appointments. So emergency triage is available 24 hours a day, 7 days a week, with appointments being scheduled within 24 to 48 hours. As an organization, we have quarterly workforce planning to ensure that our enrollee provider ratios are appropriate. This evaluation is used for all clinical positions, so dentists, dental assistants, hygienists, in addition to the office administration staff and support. Next slide, please. So where we are at today, our current average access times for our tri-state area, which is Oregon, Washington, and Idaho, is currently at 20 days for 2024 to date. We broke it down further by state. So Oregon is at 24 days, Washington 19, and then Idaho at 17. And again, emergency appointments being within goal at 24 to 48 hours. Next slide, please. So as we're providing an update today, I thought it would be helpful to kind of go back to where we were in October of 2023 to start with a review of kind of where we were then and then where we are today with some exciting updates. So throughout 2023, we did have a few geographical areas that were not at goal within that 30-day average appointment time. For our Eugene area, Lane County, which included our Eugene and Springfield offices, we had multiple provider openings. This was due to an unfortunate series of events with multiple providers leaving at one time due to retirement, moving out of state, and then another not returning from medical leave. This provider change created a callback list for our patients. So if appointments could not be accommodated within 12 weeks, then all of our members were placed on a callback list. That was worked in order of wait time once appointments were available. Also in Lynn County for our Albany office specifically, we had some ongoing recruiting efforts for two dentists throughout 2023, and with appointments being scheduled out about 8 to 10 weeks. Next slide, please. So today I'm excited to tell you about some efforts and successes that we've had in just these last few months. So throughout the last year, we did have dedicated recruitment efforts for these geographical areas. We did bring on one new provider to our Eugene office, Dr. Rappel. She was hired and onboarded in August, fully up to speed with her schedule open today. Also, throughout these last few months, due to a request from PEBB and OEB staff to expand that scheduling window so that members could make an appointment instead of being waitlisted, We did review that internally. Our providers were fully on board with this. So schedules were expanded to allow scheduling out from 12 weeks to 20 weeks, and that happened in early February. PEB and OEB members have been given priority scheduling and access to that expanded schedule. So in early March, we did an outreach message to the 667 PEB and OEB members that were on the wait list, notifying them that appointments are available due to that expansion of schedule. It was an electronic that was meant via their preferred contact method, and just let them know appointments were available and ask them to call in for scheduling. With that outreach, in addition to the manual outreach that our office has been doing to patients on the callback list, we have reduced that wait list by 42% just since the beginning of March. We do have appointments available, so all members have received at least one outreach, and we continue to outreach to get those remaining members scheduled. The appointment center, when OEB and PEB members are calling in, are transferring those members to the offices for scheduling. So no additional PEB or OEB members will be placed on a wait list for Eugene and Springfields. We also will be we're working internally now on an additional electronic push like we did in March for those remaining members to let them know that appointments are available to schedule as well. Next slide, please. So we have had a recent uptick in candidate attraction. This slide represents the new providers hired that will be starting late summer, early fall. This is not a total count of our providers. So I am really excited to share today that we have officially signed 2 new dentists for Eugene. They're going to start early August, and then 1 new dentist for Springfield that will start early September. This will make us fully staffed for both offices with a total of 6 providers and 8 hygienists. Our Eugene office will have 1 male and 3 female dentists and 2 male dentists at Springfield. This is going to make an even split of gender for those patients that prefer one over the other. And these providers also have a range of languages and areas of additional training that we're confident that patients will find a provider that they connect with in Eugene and Springfield. With the addition of these new providers, it's going to increase appointment availability by 100%, which is huge. For Albany, we've also hired 2 new providers, both starting late summer, early fall as well. Corvallis, which is very close by to Albany, has 3 very tenured providers that are covering for the Albany office until these providers start. For Albany and Corvallis, this will make a total of 5 providers and 8 hygienists between those 2 offices. As PEB members, highly utilize our Salem offices as well. Between our Liberty and Lancaster offices in Salem, we remain fully staffed with 7 providers and 11 hygienists. And next slide, please. So just a review of our network standards and a reminder, Willamette Dental has nearly 50 dental office locations across Oregon, Washington, and Idaho. We do not define a service area or have an eligibility rule, as members may contain care at any of our locations. In evaluation of our current membership, we do know that members are willing to access care, and this heat map here shows that members in Central and Southern Oregon are traveling about 60 to 130 miles to the closest office, and then we do have members in rural areas that are accessing Richland, Washington office in addition to our Idaho offices in Nampa and Meridian. In evaluation of April membership for PEB, on average, members live about 12 miles from our primary providers. And next slide is just that formally concludes the updates that we have for you today. We are looking forward to being fully staffed and onboarding these new providers in Q3 and continuing to provide the excellent care for PEB members. So I will open it up for any questions at this time.
Thank you. I'll go ahead and call your attention to the question in the chat. Oh, Emily, please.
Yeah, congratulations on the new providers that you've been able to hire. I just wanted to follow up and ask, what were the languages that the new dental providers speak?
Yeah, great question. I'm going to see if Joanna or Dr. Whittemore know, and if not, I will get that information to you.
Tiffany, I don't, but we can find out pretty easily and get that information over to them.
Joanna,
Awesome.
I know
Oh,
2
you
of the
do?
providers.
Great.
Yeah.
Oh, wonderful.
One
Go ahead.
provider speaks Vietnamese, another provider speaks Korean, and And I'm not, but I'll get back on the other 3 providers. I'm not sure their other languages, but I do know that they're bilingual. So we do have a lot of diversity in language coverage.
Great. And then do you know if they're also bicultural?
Yes, they are.
Okay, awesome. Thank you.
Yep.
Thank you, Ali.
Yeah, I just wanted to thank Climate Dental for presenting to the board. As Tiffany mentioned, the board asked them to report a year ago due to a significant number of members having access issues that were really quite significant. And it's encouraging to see some of the hirings and see some of the access issues in that waiting callback list dwindling. But we're speaking from staff's perspective, we're not seeing a number of complaints being reduced. It is actually more the opposite direction. And so I would just recommend coming back in 6 months, getting an update once the providers are on board, and hopefully we can move forward and members will be able to access services that enroll in Climate Dental. Just throwing that out there.
Yeah, absolutely. Happy to come back and provide another update. Thank you, Ali.
Yeah, thank you.
Thanks, Ali. And thank you to the Willamette Dental, not only for the services you provide, but for tightening up your presentation and helping us catch up a little, and for the good questions and responses. We'll look forward to the next time. Thanks for your efforts in the field. And with that, I will hand it over to our VSP team.
Good morning, everybody. I'm going to actually share my screen and run the presentation. It'll just take a second for it to load. Great. Good morning. I'm Valerie Swires. I'm the Large Group Market Director. Chantel Gordon is the Senior Account Manager that works with me on to help manage PEBB, and she is present with me today, and she'll be viewing, but she will not be speaking. I want to thank you for your partnership. You have been a client since 2002, so for 22 years. We are currently working on your renewal, and I believe we have come to some finalizations that we will just sprinkle in as we go through this. But we're going to start off by talking a little bit about VSP's 2023 impact report. Then we will look at member engagement and utilization, convenient access to care, give you a little bit of an update on our network, as well as share with you about On-Site Eyes, which is a mobile clinic that we performed in 2023, but also first quarter 2024 in Coos County. And then we'll wrap it up with a little bit of a prescription. So thank you all for your time. This is VSP's second annual Vision Impact Report. It's an opportunity for us to spotlight as well as celebrate some of the key corporate social responsibility efforts that we've undertaken across our enterprises, especially in areas accelerating health equity, empowering diversity, equity, and inclusion, as well as advancing sustainability. This report offers several examples of how we're demonstrating great progress within these areas of focus, both through new programs as well as decades-long initiatives that have helped define VSP's commitment to care for many generations. It also allows us to highlight areas of our shared culture like employee giving, as well as volunteering. I did put in the chat a link to our complete Vision Impact Report. It is over 45 pages long, so I will not be going into all of that. I just picked out a few snippets that I thought would be most impactful. At the heart of our organization lies a profound commitment to our purpose, our values, and culture, and we're recognizing them as the driving force behind everything that we do and how it has really shaped our identity for almost 70 years. Our purpose isn't just a statement. It really is at the foundation of everything that we do, and that is to empower human potential through sight. Our values are we care, we trust, we empower diversity, and we are one team. And I'm going to share a little bit about how we do that. So in 2023, we hit a milestone helping 4 million people in need gain access to no-cost eye care and eyewear. And this has been since the inception of our Eyes of Hope program. And this includes donations of 2.5 million pairs of eyewear to charitable organizations, as well as doctor missions around the world. In addition, we've donated 21 million in funding for vision care to help communities and individuals find relief during and after a disaster. This doesn't just apply to those people who don't have access to vision care. It also applies to our members. So if a PEBB member has lost their glasses or damaged their glasses in a disaster or just need new materials, they can participate. They can contact VSP. We will provide them with a voucher to be able to get those materials, and it's not something that is hitting PEB's utilization. We are also very committed to our network and creating the next generation of providers by investing in scholarships and grants. We awarded over 112 student funds, 241 participating programs, creating professional pathways to optometry. We go out and we partner with with historically Black colleges to educate their students on the value of the field of optometry. We bring our mobile clinics and we provide eye exams as well as eyewear for those in need on the campus. And it's just been a great way for us to really promote optometry and increase the diversity of our network. We're also committed to sustainability, and Marchon, which is the third largest frame manufacturer in the world, which is owned by VSP, is committed to producing 50% of our eyewear frames from sustainable materials by 2025. We are currently at 33%, and that jumped 8% in 2023. Click over into member engagement and talk a little bit about not only PEBB and what we're seeing with you, but also what we see for our book of business. When we think about member engagement, it really goes hand in hand with utilization. Are people going and getting their eye exam? Are they aware of the value of the benefits that they receive? And what we found is we looked at our top 100 clients with the most engaged members, and we found features about their plans and offerings that resulted in these findings. And PEBB Vision benefits actually meet all of these qualifications. And as a result, we see that you have very engaged members utilizing the plan, and your average claim frequency for the basic plan was 104 claims per 1,000 members per month in 2023. And for the Plus plan, it was 128 claims per 1,000 members per month. This is well above what I see as a standard for my book of business. A lot of times when I break it out and I look at, the public sector versus the commercial sector, the public sector, your claims and your utilization is typically much higher. And that's because of the incredibly valuable benefits that you offer. You're offering and frequency annually of exam lenses and frames. You offer a buy-up opportunity that allows people to select a richer plan that best meets their needs, as well as low pays for that eye exam of $10 or less, as well as higher than standard frame allowances. And all of these things help to produce an increase in benefit utilization. It also helps with in-network utilization. PEBB has excellent in-network utilization at 96%. 84% of those are going to private practice, 16% are going to retail or online, and 62% are going to one of our Premier Edge providers. And our Premier Edge providers, oops, something just happened to my presentation. Are you able to still see it? Yes, it looks like you are. Our Premier Edge providers are those providers that are offering access to the greatest selection of our exclusive member extras, rebates, and discounts, as well as advanced technology in diagnostic capabilities. I'll go into that a little bit more in a minute, but this is just an overview of your plan design. And one of the things that we had recommended for your renewal was to increase the contact lens allowance on the Plus plan to match the frame allowance, which is $225. And so it's going up $25. It'll add a little bit of difference between the basic plan and the Plus plan for those contact lens wearers. And I think this will be a nice value add for those that are enrolling in the Plus plan and wearing contact lenses. When we look at the total premium for 2023 versus 2022, 2021, you can see there is a little bit of an increase, 6% increase in premium compared to 2022. The overall driver for this was we had about a 3% increase in overall enrollment, and that we had an 8% increase in enrollment in the Plus plan, which is the richer benefit plan. We're going to continue to see this because as your population ages and as we see inflation hitting the costs for materials and goods and services, you will find that people can do the math very quickly and realize that spending a little extra and enrolling in that Plus plan is going to get them the savings and the coverage that they need. This is your enrollment by plan and growth for the last 3 years. And then I also put in first quarter 2024. And we currently have 47% enrolled in the Plus plan. But year over year, we're seeing an increase in enrollment in that Plus plan. And then when we look at the eye exams and the percentage of those that are getting an eye exam, and we compare the basic and the Plus plan, you have 39% getting an exam in the basic plan, which is excellent. When I look at our book of business, our average is 34%. So a few percentage points higher, but your Plus plan is getting an exam 62%, which is very much what we see when we have a base and a buy-up plan, in that there's greater utilization, more opportunity for preventative care. And then speaking of preventative care, when our doctors are doing an annual exam, they are seeing the health of the entire vascular system. An eye exam is the only place where you have an unobstructed view of the 9 different types of vessels that are in your body. This gives them an opportunity to potentially diagnose up to 270 different medical or health conditions during that exam. And so our doctors are also participating by sharing data with us on members who have diabetes, hypertension, high cholesterol, diabetic retinopathy, macular degeneration, glaucoma, And we are able to share this data, and we are sharing this data with Providence, and we've been doing so since 2013. It is a way to potentially, close that loop of, if one of these is diagnosed, that they can then be handed off to a care manager or someone that can help further with these conditions. When we compare your percentages of getting an eye exam by, generation versus VSP's book of business, you can see quite a bit higher. And then when we look at the conditions that were identified early, you are running a little bit lower in every category except for millennials. The other thing that we are doing is we do exam reminder letters. And so if someone who is a known diabetic has not received an exam in 14 months or more, we send out a letter, and then we track that for 180 days. And we had a 15% effectiveness ratio. When sharing this data, like with Providence, they can also bump this up against their exam utilization, because most people who are going in for a diabetic exam, it is being billed to medical. However, if the VSP provider is not participating in the medical network, they can bill VSP, and we will reimburse for that diabetic eye exam with a $20 copay. And some additional benefits that you're offering, light care. You had almost 2,500 claims in 2023, and then vision therapy, 99 claims. In comparison to 2022, light care was up 13%, and the vision therapy was down 13%. We don't see a tremendous amount of utilization with the vision therapy. It's wonderful for those people who need it, but the percentage of people that are in need of it is small. And then when we look at the plan offering as well as that frame, as I mentioned, those members that are most engaged have higher access or higher frame allowance. Your Plus plan offers this, and it's covered 68% of frames that were selected in full in 2023, and the average out-of-pocket cost was only $24. So very, very valuable benefit. When we look at the average frame cost across the United States, you can see the West Coast here is in green, and that's 225 to 250. So you guys are right in line with what we're seeing for the West Coast. When you think about your vision benefits, it's not just about the premium that you're paying or the benefit that's being offered. It's those out-of-pocket costs. And so we're very considerate of this, and our exclusive member extras, as well as our negotiated discounts, saved your members $4.7 million in 2023 in out-of-pocket costs. So, again, very valuable. And these are just a few of those exclusive member extras. One of the most popular is the get an extra 20 on featured frames, as well as get an extra 40 to spend on select featured frames. These are things that they can search for a provider and find providers that are offering these valuable discounts. In 2023, that savings was a little over $41,000 in out-of-pocket costs for those members that selected one of these featured frames. So very valuable. And then convenient access to care. VSP has one of the largest and most comprehensive network of eye care providers in the industry. We are very committed to continuing to expand access in rural areas by offering innovative solutions in healthcare deserts by piloting proof of concept mobile clinics, as well as offering programs to help with student loan repayment to attract and retrain providers. assisting providers to uncover ways to make their practices more efficient and profitable. And earlier this year, we announced that Kate Renwick Espinoza, our Chief Network Officer, as well as VSP Vision Care President, she's transitioning to our Chief Network Officer and Network Group President. And she has been playing these dual roles since November of 2022. And while doing this, she really felt that it was important that as we look to the future, that she just focus on the one role as being the Chief Network Officer, and looking to maximize opportunities in growing our network. This will allow her to focus on strategy as well. And in the last year, we've added 11,000 access points nationally and recently negotiated the retention of Coastal Eye Care that had 4 practices in Astoria, Tillamook, Seaside, and Long Beach, Washington, as well as Precision Eye Care in Curry County. I see a hand up, please.
Thank you. I just wanted to call your attention to the time. It appears that we're running over and maybe you have another dozen slides. So if you could go ahead and help us come to a close, that would be lovely.
I will do that. Thank you so much. I'm sorry. I think the most important thing for me to share with you is on-site eyes. This was a clinic, mobile clinic that we did in Coos County. We did this in November of 2023. We had 1 lane and we were able to do 81 eye exams over 3 days, and we dispensed 60 materials benefits for glasses. And then in February, we had 2 lanes, so 2 doctors, and we did 53 eye exams over 3 days. We dispensed 32 materials just for PEBB, but overall we did 99 exams. We allowed other clients to participate. So thank you very much for your time, and I appreciate it.
Thank you. I appreciate the focus and attention on the social entrepreneurship models and the ways that VSP is leveraging their opportunities to really invest in the health of our communities and vision, and not keeping a narrow focus on those with this kind of a benefit. Anything for our presenter quickly before we go ahead and move on?
I will stop sharing. Thank you so much. Oh, I see a hand.
Emily. You're still muted, Emily.
Sorry about that. Thanks so much. It's exciting, the results of your mobile clinic. And I just put a question in the chat. I was just really happy to hear about your scholarship and grant future workforce efforts with historical Black colleges. Just curious if you have any of those efforts going on in Oregon, specific to any colleges, universities, or employers in Oregon.
So when we do these events, we're really looking at those universities that have a large population that will allow us to, really attract higher percentages of the Black, Latino, and that is where we find that we have the greatest opportunity for growth within our network. I don't believe the Oregon universities really are trending in those numbers that would allow us that access. But we do, our scholarships, our grants, and things like that are not limited to those colleges. So we encourage anybody who has an interest to participate and to, apply for those. But
okay, yeah, it might be worth exploring. We have a really large Latino population in Oregon, and also a sizable initiative to diversify the healthcare workforce and including eye care and dental and everything. So thank you.
Thank you.
Thanks, Emily, and thank you, VSP, for your presentation. I will turn our attention now to Humberto Chacon for our canopy update. Hi.
Great. Thank you, Dawn. If you all want to show you your slides, that'd be great. Thank you. If we could actually go to the next slide. Hello, everyone. I'm Humberto Chacon, the Canopy Customer Success Manager for State of Oregon, and I'm joined today by my colleague Anna Miners, who will help me with this, and we will go over briefly our services and some updates and show you some PEBB data and whatnot. And we want to thank you for your continued support over the years. So there's our agenda. Let's go ahead and get right into it. And wanted to just let you all know that, you know, our mission is about creating happier and healthier futures by breaking down barriers today. And our values are building authentic relationships, initiating relevant change, and connecting with kindness. And, you know, we strive to do that with every relationship that we build and everyone that we try to help. So with that, if we can go to the next slide, I will pass it on to Anna to briefly go over our services and some updates to our member portal and our peer support program.
Thanks, Humberto. Hi, everybody. Appreciate you having us today. I'm Anna Miners, the VP of Customer Success at Canopy, and happy to be a part of the conversation. I think most of you are fairly familiar with the benefits that we offer. I did, as Humberto said, want to just highlight a few key points, if I can talk today, around the counseling components and the diversity of our network. Humberto has some statistics that we'll plan to share in a few minutes here, but really highlighting the ability to match members with criteria that are important to them, which we'll talk about on the next slide here, including health plan integration whenever possible. I also wanted to highlight our improved digital tools and the enhancement to the member experience that way with virtual care navigation and self-scheduling. And then the last thing from this kind of overall slide that I do want to spend a few minutes on is the virtual peer support program and some innovations and changes that we've made there that we think will be valuable to PEBB members. So next slide, please, and thank you. So as I've heard many others talk about in our call today, you know, culturally responsive care is a top priority for us. We want to make sure that we're matching members on criteria that are important to them. So we're continuously evaluating, recruiting, but also paying attention to retention of our provider network to make sure that we're adequately meeting people's needs for care. So our retention in the last year has been about 97%. And we've added 15% more providers with the framework in mind of making sure that we're being cognizant of cultural competency, the ability to match based on language spoken, other important variables for folks, including health plan integration, as I mentioned. And then the next slide is, as I was saying a moment ago, really focusing on the improvements to our member hub or the online experience, both through the app, both through Canopy EAP app and the member site, with digital tools really to give people autonomy in navigating the benefits and matching with right level of care. On the next slide, it shows when you log into our site, either through the app or through the member site, you are greeted with what we call the virtual care navigator. It's optional, people can close out of it. But what the virtual care navigator allows us to do is really make sure that we're matching people with right level of care. So members are encouraged to complete a brief initial assessment around what's bringing them to the EAP, how distressing is that topic, and based on their responses, then are matched with a curated recommendation that aligns with PEBB's benefit. And through the virtual care navigator, people can connect directly in self-scheduling with counseling. They can connect with the peer support, which we'll talk about in a moment, any of the resources for life. And so it really has that benefit of making sure, again, it's right level of care, that people are accessing the care that they need, and that they're getting some help in resource navigation. The peer support program, I'll talk about that here on the next slide, please. Thank you. You know, we're really pleased to be working on an enhanced offering for PEBB. This will be available starting June 1st in replacement of the current peer support offering. The partner that we're working with, TogetherAll, has been in the virtual peer support space for many years. And there's some key reasons that we like the offering. One is that it offers members several unique ways to interact with the platform. So you can, consistent with our mission, you know, it's reducing barriers. And so you can, you're anonymous on the platform, and you can either read, you know, what other people have posted and not engage in a conversation. You can post and engage an inquiry or a conversation or a request for support. And you can also provide support to others. So sort of a diversity of ways folks can interact, allowing for the opportunity to self-select into communities with folks that have shared lived experiences. There is occupational specific matching that's available within the platform. And what I like a lot about the member experience is that it also is monitored 24/7 by licensed clinical staff. So there's a level of care integration and care escalation that really is aligned with our goals to make sure that we are meeting people where they're at, escalating care if we need to, providing a safe space for people to connect. There's also integration with our Canopy clinical team and our call center. So if there is a situation where intensive care management or intervention is needed, that can be taken, you know, off-platform intervention to make sure folks are getting the support and the care that they need. So really, this is helpful, as I mentioned, you know, in alignment with our goals around reducing barriers to access. As you can see here, some statistics around our capability to reach underserved populations, connect people sooner. There's a broad range of needs that folks can connect with support on the platform. And then that integration with Canopy's other services as far as both care escalation, but also resource integration are things that I think that you'll enjoy for PEBB members as we're rolling this out in the upcoming month or so. Briefly on the next slide, it's again, just kind of a reminder or an overview before Umberto spends the rest of our allocated time on statistics, but just a reminder that equally important to member support that we provide is the support that we provide on the employer level, specifically around, you know, consultation, training, critical incident response, and how these tools are really important to maintaining well-being in the workplace, but also ensuring consistent promotion of EAP benefits so people are aware of what's available to them and utilizing what's available to them. So Umberto, I think we'll talk a little bit more about that, and I'll turn it back over to you.
Yes, thank you. Thank you, Anna. Excellent. If you can go to the next slide. And so as she was mentioning, we do have regular communication. Here's some thumbnails of monthly and quarterly newsletters that we send out either to agencies or subscribers who've come through the member site, as well as leadership support that we send out quarterly. And if we can go to the next slide, you can see some examples or actually upcoming topics that we will promote. So some agencies choose to kind of piggyback off of our promotional calendar to get the word out about specific services or topics. We can go to the next slide. Yep, here's just some examples, trying to be colorful, not too wordy, get people's attention, have them actually read what we send out. So just some examples there. And if we can go to the next slide, actually 2 slides down. we'll get into PEB data. So we're answering calls for PEB members in less than 10 seconds on average. Our call center is always open. It's 24/7. And when people ask for a coach, it's typically within 1 to 2 days that they connect with the coach. And if they're asking for a counselor, even with their preferences being taken into account, it's typically about a week before they have their first appointment. So very fast access to care. We can go to the next slide. We do a pre and post assessment on folks that come to us for counseling and look at several different outcomes. And what we're seeing with PEB members is that there's about a 3 and 5% decrease in absenteeism. There's about a third of the members are reporting an increase in focus or less presenteeism. And then something that's actually hard to move the needle on is life satisfaction, and we're showing a 16% increase in life satisfaction. So we can go to the next slide. As you know, last year, or actually in the current plan year, but July of last year, we offered 2 additional session levels in our plan to agencies. So we added 6 and 8 sessions. And here's just an overview of the number of agencies by session level and the total FTE for those agencies. So you can see that, most are still at 3 or 5, but there are some that have gone to more, have gone to 8. And we have heard from some agencies that they're reviewing the number of visits in their plan and thinking about switching to a higher level. So we'll see how that goes over the next couple of months. We can go to the next slide.
Just a quick question. We no longer
Yes.
have agencies that have 0. Is that right?
There's a few that haven't chosen anything. So we actually picked up a few that hadn't chosen anything, smaller ones. But yeah, there's not an option per se of 0. I mean, I guess you can just not offer it,
Yeah,
and I'm not sure how many agencies that is, but it must be very few.
And then OSU still has some other providers, right?
Right.
Okay.
Right. Yeah.
Thanks.
We'd love to cover them if we could. So utilization, it was at 8.1%, which is actually down a bit from the previous year, but that's because there are more agencies being covered with a greater head count. The actual number of people that received individual referrals to providers or services was about the same at 4,500. And when we look at our whole book of business, PEB is slightly higher than our whole book of business. Our book of business is at 8%. And then when we look at standalone EAPs in the US, PEB's utilization is more than 50% higher than kind of the standard out there, or the average, which is about 5%. If we can go to the next slide. So over 15,000 PEB members engaged with services, including those for individual referrals or services, and many for group services such as webinars, orientations, critical incident stress debriefings. And that's actually about a 50% increase in those group services compared to the last couple of years. So quite a bit of interest among agencies for trainings, orientations, also to provide that critical incident stress debriefings. So really seeing an increase there. And then we also provide the member hub, which Anna talked about. And what we saw last year, and this is not part of the 15,000, is about 9,000 users going to over 39,000 web pages. So that's actually about 3 times as many web users than the last couple of years, and about twice as many web resources access. So all those promotions and whatnot that we've partnered with agencies to do, we're seeing quite an increase in people going to our member hub that Anna talked about. So that's increased. And then in addition to those member services, something that Anna talked about was the organizational support. So we consult with managers about situations in their team, or that they'd like to talk to a clinician about. And done over last year, we did over 50 management consultations, and those were around performance concerns of employees. There was conflict in various staff that managers wanted a consultation with. And then there was also some consultations around leadership support and development, some consultations around goal setting, managing remote staff, providing employees with feedback, that sort of thing. So it's a great resource for managers. Right? Dawn, did you have your hand up? I'm sorry. Probably have to wrap up.
I don't actually.
Okay.
Thank you. I wanted
Yeah.
to call your attention to Christy's hand, which is up.
Oh, I didn't see it. Oh, Christy.
Yeah.
Thanks, Dr. Mutner. Humberto, I just had a quick question back on the utilization rate slide. Can you just tell us what goes into your utilization percentage? What types of
so
services do you count?
We're very conservative in what we count as utilization. We just count those cases where individual was referred to a provider or service. So we don't count web hits, questions, benefit fare, participation, something like that. It's just those folks who received a referral to a provider or service. So we're very conservative kind of in the industry in what we count as utilization.
So that's for EAP counseling, work-life services, and then does that include your organizational support and management consults that you do?
No, just individuals who are referred, not groups.
Thank you.
Yeah. It's so, you see all sorts of utilization numbers, right, Christy? So we know. I'm glad you asked that question, because
yes,
everyone seems to define it differently. We are on the very conservative side. Just individuals.
Appreciate that. Thank you.
Yeah. So if we can go to the next slide, I did want to highlight that, our call center is open 24/7, right? So it can serve as a mental health hotline for members. And in 2023, 229 members did receive in-the-moment phone consultations with a mental health professional. So those could have been pressing issues. And that's something that, we've seen a slight increase over time in that, but just wanted to call out that is available, and we are here to help folks in the moment. If we can go to the next slide, just very quickly. While most cases are clinical or counseling, 59%, there's still a significant number of resources for life, right? About 41% of the cases are resources for life. So adult care, child care, legal, all that sort of thing. We can go to the next slide. Just a quick review of kind of the last few years. As I mentioned last year, prior to the pandemic, anxiety was about the 5th top presenting issue that people wanted to see a counselor about. During the pandemic, anxiety went up to number 1. So back in 2020, it has fallen off to be the 2nd, but it's still, it's still up there. It's 340 members last year wanted to see a counselor, and their presenting issue was anxiety. So seeing that continue to be up, and then grief showed up as one of the top 5. So more part of that is maybe just more awareness that we provide that, but we are seeing a slight increase in that. And then if we can go to the next slide, which is the last bit of data, you can see the work-life issues. So legal has perennially been the number 1 referral on the work-life side, but resource retrieval is now number 2. So we're seeing an increase in resource retrieval. Part of that is due to our member hub making it very easy to get a request or resource retrieval, but we are finding that members are looking to us to help them with all sorts of different things. Sometimes it's social drivers of health. Something that someone is looking for help with finding transportation or housing or food programs or various programs and community resources. But also sometimes it's help with navigating various other benefits that PEBB offers and finding providers, right? They look to us as a helping hand in finding care. So just wanted to kind of point that out, that has increased in the last couple of years, really. And with that, go to the next one. And if there's any questions, I know we were short on time there, but appreciate you all listening and your partnership, over the years. So, no?
Thank you for those insights,
Okay.
Humberto and team.
Absolutely.
Yeah.
All right. Thank you.
There's some really interesting data in there, and a better understanding of what you're seeing there might be a really useful insight into what our members are facing out there.
Yeah. Yeah, absolutely.
Greg.
If you can hear me, I would like to say from, as Kim said, I've worked in corrections now for almost 24 years, and our staff members, we attempt as best we can to let them know who you are and what you're there for. And we appreciate everything you've done for all of our staff members. So thank you.
Thank you. Thank you. Thank you for your partnership. DOC's been a great partner, really getting the word out, and we have very strong utilization from DOC, and really that's a testament to us working together.
Yes,
so thank you.
Very good. Thank you very much. Thanks, Greg and Kimberly. All right, Humberto, thank you very much.
Thank you. Take care.
All right, let's
We'll
go
log off.
ahead and transition to it's Glenn and then Margaret and Cindy, and I'll just acknowledge that we're running a little bit behind. So at whatever level you are able to tighten up your presentations, that is appreciated. Glenn Bailey, are you there?
Yes, I'm here. Thank you. And I will try and be as quick as possible here. I'm going to talk about, excuse me, the OEB PEB Summer Research Group that was proposed and considered by CL. Where basically it was proposed to really explore opportunities for traditional health workers in OEB and PEB plans. Just a little bit about the purpose of these research groups. They started in 2023. We did one for doula services and one for GLP-1 drugs. They were made up of both staff, consultant, carriers, as well as representatives from the board. We met twice monthly, started in June, and we really pretty much went through September, and then it went to CL, who made recommendations to the boards. For 2024, we're proposing to do a research group on traditional health workers. This really, this idea stems from a conversations we've had about provider and care gaps in rural areas, and opportunities to explore additional provider workforce options to really help close those gaps and meet really the diverse needs of members. Traditional health workers were recently added by the Oregon Medicaid Provider Network. The 2024 Summer Research Group will focus on topics and questions related to incorporating these workers and supplemental providers in OEB and PEB plans, and will follow the same process and really structure as 2023. And just on a basis, a basic understanding, what is a traditional healthcare worker? Or it's a trusted individual from a local community who may also share socioeconomic ties and lived life experiences with health plan members. They have historically provided in-person and a community-centered care by bridging communities and the health systems that they serve. Some of the benefits for traditional health workers, for PEB and OEB members, it will help improve health outcomes, reduce disparities, improve access to care. I mean, this can be especially important in behavioral health and substance abuse, and then help reduce overall costs. And unfortunately, I can't see if there's any hands. So if Dawn, if you could just mention to me if there's any questions that come up.
You're good,
The
Glenn.
traditional health workers are broken into really 5 categories: community health workers, peer support specialists, peer wellness specialists, and personal health navigators, as well as birth doulas, which we are going to be covering for the 25 plan year. They also to note that traditional health workers are, on a registry, and they must meet certification and training opportunities or requirements through the Oregon Health Authority. Some of the topics we're really going to get into is what impact traditional health workers may be having on the Kaiser and MODA plans they already service. Kaiser utilizes traditional health workers. MODA has it with their CCO plans, but not offered to OEB and PEB. And then Providence doesn't offer them at this point. What is the state scope of practice include? What are the different services they provide? What are the different requirements that they must meet? What are the lessons learned from Oregon Medicaid? Have they seen, a big impact by adding these workers? Have they seen any issues that have come up? And then what impact could they provide for PEB and OEB members? And then just looking at, what role they will fill in these geographic areas. And then just, are there other opportunities for workforce investment? This is a number of questions. Others I'm sure will come up, but these are just a list of some of the questions we've identified so far. The next steps were, we took this to CIAO in May, who recommended to both the OEB and PEB boards that we move forward with this work group to do for traditional health workers. Again, there would be bi-monthly meetings will be scheduled between June and August, and then we'll begin researching the topics. One of the things that I wanted to really bring up before the PEB board is that in the last year, we used 1 member from PEB, 1 member for OEB for each work group. We took another look at the related statutes for public meetings, and it really, we can do actually up to 3 because PEB's quorum is 4. So, we would really, this would be, an opportunity for us. We wanted to point out that we would need volunteers from PEB, the PEB board, who would like to sit on this work group. Are there any questions?
So Glenn, this is Ollie. So if any PEB board members are interested, would you like them to contact myself?
Or they can, contact me.
Okay.
And I can pass it on to Mercer.
I just wanted to recognize Greg and Andy. Sorry to jump in, Don. They've been participating on the CIAO committee and have really been active participants, and hopefully have learned a lot, gotten a lot out of the experience. And I would definitely recommend if anyone's interested in letting us know, and we'd be happy to get that set up.
Thank you, Ali. Yeah, we are certainly looking for volunteers both for CIAO and for this work group too.
thank you for running those groups in collaboration and for the opportunity for board members to participate. Anybody who's ready to volunteer, Greg, Andy, or others, welcome. Anything else or questions for Glenn at this time? Hearing none, thank you very much for that work. Thanks to Xiao for the work that you do to help advise us on how to think about some of the more tangled issues. I'm particularly interested, Glenn, for THWs. They have a potential superpower, THWs, traditional health workers, in terms of being able to reach some of our most highly impacted and priority populations, and being able to provide the kind of navigation and facilitation that those individuals and communities need to improve health outcomes, especially relative to those, for example, who live in areas with better access, if we're talking about the rural population. So I'll look forward to seeing those research questions framed with some equity thinking built in along the way. Thank you very much for that work.
We will do. We'll do on that. That's a good point. Thank you.
Thank you. All right. Hey, thanks for that note, Emily. All right, so we are running short on time. We have only a few more minutes. Margaret, I will go ahead and hand it over to you, and then we may need to defer. Cindy, we may need to defer for you to next time. So please jump in if there's something that needs to happen today. Margaret.
Sounds great. Thank you, Chair Mountner and members of the board. Glad to be here. I have 2 quick slides to go through, so we'll see. We may be able to move through this pretty quickly. Wanted to provide an update on the spring work of the Innovation Work Group. I'll preface this by saying this spring, the Innovation Work Group's main topic was really to focus on our contractual performance guarantees with carriers. I want to note this is an update, and we can schedule for a future upcoming board meeting an in-depth discussion and review of all the performance guarantees. They are described here on this slide, the guarantees that we are pursuing for 2025 contracts. I'm going to focus on the yellow arrow, which is specifically the aspect of the contractual performance guarantees that Innovation Work Group reviewed this spring. And specifically, currently in our medical contracts, we have 5% of fees at risk, administrative fees at risk for plan administrative measures. And these are measures related to things like claims processing timeliness, claims processing accuracy, some of the kind of industry standard insurance measures. Carriers have generally been performing well on those, meeting our expectations. So the Innovation Work Group took the perspective that there's an opportunity to shift those fees at risk to a sort of more higher priority, more meaningful area in 2025. So the Innovation Work Group did a lot of work this spring to review options and look at the landscape around behavioral health measures. And if we can advance to the next slide, IW developed a collection of behavioral health measures that we are recommending move forward in our renewal contracts with medical carriers. This would mean that in 2025 contracts, we'd have 5% of carriers' administrative fees at risk, specifically on these behavioral health measures. And you can see this nice slide, and I want to give a lot of credit to the Mercer team because they really helped us in formulating the thinking about this and kind of condensing all the information. This is really color-coded to show the different categories of measures. They include both in-person wait time standards, virtual wait time standards, time and distance standards, which some of these are really becoming, requirements of CMS. In terms of provider network access and adequacy, and then some reporting and performance guarantee standards around provider diversity and provider demographics being included in directories. So the approach we're proposing for 2025 is that you can see in the last column, the 5% of fees at risk would be allocated across these measures. And 2025 would be a report-only baseline year, so that carriers would meet the the performance guarantee standard, provided that they report. In 2025, we've also included an additional 1% of those fees at risk tied to an improvement plan. And what we plan to do is ask carriers to also submit an action plan to address at least one area of deficiency identified. Now, the plan is that for 2025, this would be report only on these measures, and then we would receive that data next year, review it, and for 2026 contracts, establish targets and have fees at risk attached to carriers meeting their targets that we would identify in the coming year. So in a very high level, quick overview, that is kind of the crux of the innovation work group's recommendation. Today, really just looking for any board questions or general consensus in terms of moving forward with this approach.
Thank you, Margaret. So that applies for a calendar year at a time, this decision?
Yes, this is for the plan year. So the 2025 benefit plan contract for our medical carriers, which aligns with our calendar year. For OEB, it's the plan year because it's not quite aligned with the calendar year. So yeah, but for PEBB, it's 2025 calendar and plan year.
Appreciate the quality of the thinking there as we move past time and distance, which used to be what it took to qualify for provider network adequacy and no longer gives a complete or adequate picture. Any questions for Margaret? Hearing none, I will open the floor for any other business or public comment, please. Margaret, please.
I was going to say one final update on the innovation work group to go along with this. And I'm sorry, just to note, the work group at this point is taking a break over the summer. We plan to reconvene in the fall. Currently, Kimberly Hendricks and Sean Parkman are your PEBB representatives on the work group. We are open to welcoming an additional PEBB member if there's a third member of the board who would like to get engaged. Want to note that we have some turnover in OEB board seats. So right now, we just have one OEB member on the work group, Robert Young. And in the coming months, as new OEB board members get seated, we're going to be ensuring we have a full roster on the innovation work group before we reconvene in the fall, and look forward to additional opportunities to work on performance guarantees and other priority topics for the boards. Thank you.
Thank you. I didn't mean to cut you off. My mistake. Thanks for jumping back in.
And yeah, no problem. Thank you.
And thank you to Kimberly and who was the other participant?
Sean.
Oh, right. Yeah. And he's not here. Yeah. Thank you for your participation. This is really good work. Any other thoughts about that for the moment?
So I would just do a plug. If somebody's very much into centers of excellence and really about all the work that Innovation Work Group's doing, it's pretty painless. Margaret really takes care of us. So we'd be happy to have you help us or join us on the committee.
Thanks for that plug, Kimberly. And kudos to Margaret and the rest of the PEBB staff. Yeah. All right. Moving on to public comment. Is there any public comment today?
No
public comment other than the written that I sent you.
Yeah, I just wanted to recognize that written comment that we got because it was just part of the overall discussion we're continuing to have around weight loss drugs. And I know we'll continue to dig into that. In September, maybe we'll get more information. I'm sure we will, but I just want to recognize that.
Thanks, Siobhan. People are having profound experiences, have been having all the way along with obesity. Our awareness of it and potential for insights into it is evolving. and the harms that are being done as well. So looking forward to next chapters in terms of appropriate treatment options being accessible and better understood as we move ahead. Anything else for the good of the order? Thank you, Siobhan, for bringing that up. Hearing none, and with gratitude for all of the support, both from Mercer and from our PEBB staff, and also the collaborations across the healthcare sector. Thank you very much for participating today, everybody. See you next time. Have a beautiful day.
Take care, everybody. Bye.
Thank you.
Thank you.
Take care.
Thank you.
Bye.